I would like to thank all the members of the society for giving me this opportunity. Now, starting with the initial part of the guidelines. Why we chose this article? The past 2 decades have witnessed tremendous growth in the appreciation and treatment of sacroiliac joint complex pain, including the anatomical dissections that shed light on the innovation of the SIJ and appreciation of the extra-articular components of SIJ pain, and with the advent of radiofrequency ablation and a host of minimally invasive surgical techniques. Yet, there is no standardization of the diagnosis and the treatment paradigms. As we can see from the diagram, SIJ is composed of the lateral parts of the sacrum and the medial portions of the iliac bone. Posterior superiorly, it is amphiarthrodial and fibrocartilaginous, and anterior inferiorly, the joint has hyaline cartilage lining the articular surfaces, and it is diarthrodial, that is, it is slightly more mobile. The main function of SI joint is to bear the weight of the axial skeleton and transfer it to the hip bones. The weight can be then distributed to the 2 femurs in the standing position and the 2 ischial bones in the sitting position. Due to its position and weight-bearing nature, the sacroiliac joint has to be stabilized with several strong ligaments. The main ligaments are anterior sacroiliac ligament and the posterior sacroiliac ligaments, which is composed of further 3 more ligaments, that is interosseous sacroiliac ligament, short posterior sacroiliac ligament, and the long posterior sacroiliac ligament. Earlier in the literature, there was no specific data on the functional and clinical relevance of the long posterior sacroiliac ligament. In fact, several anatomical atlases have portrayed the long posterior dorsal ligament and the sacrotuberous ligament as one structure only. Essentially, the long ligament connects the posterior superior iliac spine to the sacrum, and the sacrotuberous ligament attaches the sacrum and the ischial tuberosity. It extends from the posterior superior iliac spine to the 3rd and 4th transverse tubercles of the sacrum. It blends with the sacrotuberous ligaments partially. It is anatomically also connected to the, I was just switching on to the laser pointer. It is anatomically also connected to the erector spinae muscle and the thoracolumbar fascia, potentially serving as a source of spinal pain. The accessory ligaments of the sacroiliac joint are sacrotuberous ligament and the sacrospinous ligament. The nerve supply of SIJ, anterior aspect, it is supplied by the branches of the lumbosacral trunk and the direct branches from the anterior ramus of the L4 and L5. Dissection and histology have not confirmed innervation from the anterior rami of S1 to S3 in the anterior aspect. The posterior aspect of the joint capsule and the posterior extraarticular ligaments are supplied by the anatomical posterior sacral network, which predominantly consists of contribution from the lateral branches of S1 to the S3 and sometimes contributions from L5 to or S4. Given the shared innervation of the dorsal ligament and SIJ complex, the pain presentations of SIJ can vary from isolated dorsal ligament pain, dorsal ligament pain with concurrent SIJ mediated pain, dorsal ligament pain with concurrent L5 S1 facet joint mediated pain, or a combination of all of these. The decision to form these guidelines was taken by was approved by American Association of Pain Medicine and American Society of Regional Anesthesia Pain Medicine. 30 partner organizations with clinical and scientific interest in SIJ complex pain were identified and a formal request for participation was sent. 27 organizations agreed. Each organization nominated a single representative. Questions and formats were developed by the SIJ working group. The resulting final unanimous consensus version comprised of 21 distinct questions to be addressed within the guidelines. A modified Delphi method was used to tabulate the comments, incorporate the changes, and converge the answers toward a consensus statement over the rounds of teleconferences and electronic correspondences. At the initial conference call, the working group committee decided that more than 50% of the panel agreement was sufficient. However, for the consensus final statement, more than 75% of the panel agreement was required. So we will be discussing these guidelines depending on the questions that were formulated. So the first question was regarding the prevalence of SIJ complex pain. It is as common as 15 to 30% in the general population, with unknown prevalence of isolated dorsal ligament pain, but this also appears to be at least as common as exclusively intra-articular pain. Further studies are recommended to assess the prevalence of dorsal ligament pain primarily based on the extra-articular injections and sacral lateral branch blocks. The prevalence is even higher in patients after the lumbar or lumbosacral spinal fusion surgeries. It increases to 33 to 59%. This can be attributed to the adjacent segment stress with increased loading or shear forces leading to the accelerated degeneration, superimposed or missed SIJ mediated pain prior to the lumbar fusion, or the violation of ligaments or synovial lining during the iliac crest bone grafting. The historical and physical examination may help predict response to intra-articular SIJ injection of local anesthetics with or without corticosteroids. However, there is minimal data to predict these results in primarily extra-articular dorsal ligament pathology. It may be reasonable to give SIJ injections even in the absence of positive provocative tests, especially in cases with negative workup for other causes or in cases with strong clinical suspicion. A biomechanical study was done which found that higher contact pressure could be seen with Faber, compression, Ganslin, and thigh thrust, the highest being in Ganslin's test. Based on the ligaments stretched, posterior ligaments were specifically more stretched in compression, thigh thrust, and sacral thrust. All the ligaments were stretched. The specificity of individual test or the cluster of tests is much less than the sensitivity. Therefore, the negative predictive value of the test is much higher than the positive predictive value. This is a grade A recommendation by the society. The inter-rater reliability of the SIJ provocation test has a wide range, Faber test having the highest reliability. Radiological imaging is important for ruling out the causes of SIJ complex pain. However, there is minimal or unclear utility for diagnosing the SIJ complex pain regardless of the imaging modality. The sensitivity of radionuclide bone scan ranges between 13 to 46% for identifying a painful SIJ, though the specificity is high, but it is still not recommended. CT scan also has inadequate sensitivity and specificity. There is insufficient evidence to determine the accuracy of MRI. However, the available evidence suggests low sensitivity and specificity. SPECT-CT has higher sensitivity and specificity for identifying a painful SIJ. However, there is insufficient evidence and the studies are very limited. In even SPECT-CT cannot differentiate between extra-articular or intra-articular pain pathology. Till now, there has been no study to differentiate between MRI, radionuclide bone scan, CT scan, or SPECT-CT to differentiate a painful SIJ from a dorsal ligament pain. For diagnosing and distinguishing between intra-articular SIJ and dorsal ligament pain, intervention-based diagnosis remains the reference standard. Are SIJ injection diagnostic? Yes, they are diagnostically valid for intra-articular SIJ mediated pain. However, multiple factors can affect the sensitivity and specificity of these tests, including the placebo effects, referred pain, neuroplasticity, central sensitization, expectation bias, systemic absorption of local anesthetics, psychological factors. Furthermore, SIJ may communicate with S1 foramen leading to the dorsal leakage of the injectate, and there can be anterior capsular defects in approximately 40% of the patients. Considering the false positive rate of 20%, further studies are recommended to validate the diagnostic criteria. Can SIJ local anesthetic injections be used for predicting response to intra-articular steroids or sacral lateral branch blocks? No, both have unpredictable value for prognostic value for injection with steroids or for SLB-RFA. Can sacral lateral branch blocks be used for diagnosis and prognostic value for SLB-RFA? Yes, SLBBs are diagnostic for pain arising from extra-articular sources, with approximately 70% effective in blocking nociception from interosseous ligament, dorsal sacroiliac ligament, and inferior dorsal capsule of the joint. However, it spares the pain associated with the distension of the full SIJ complex. There is insufficient evidence to assess the relative prognostic value of SLBBs compared with other selection criteria for SLB-RFA. SIJ has a very large surface area. However, the synovial portion has a very small capacity, ranging between 0.8 to 2.5 ml in asymptomatic individuals and 1 to 2.7 in symptomatic individuals. It has been proposed that injectate value of more than 2.5 ml are likely to be non-specific due to extra-articular spillage. Therefore, the recommended volume should be limited to 2.5 ml to prevent capsular rupture or reduce extra-articular spread. And if increase in resistance is perceived at lower volumes, the injection should be stopped to avoid tears in the capsule. In patients with suspected intra-articular as well as the pain arising from the overlying ligaments or the structures, volume higher than 2 ml might be required to block the pain generators, and sometimes more than 3 ml also can be required. The response to diagnostic intra-articular injections can be used to select the patients for surgical fusion of the SIJ. Corticosteroids should not be routinely added to local anesthetic during purely diagnostic intra-articular injections, as they may potentially increase the volume of the injectate, thus resulting in extra-articular spread. Volume of local anesthetic for sacral lateral branch blocks can range from 0.6 ml to 1.2 ml per foraminal region and should be performed at different depths. Regarding the image guidance, accuracy of intra-articular injectate spread is more with the fluoroscopically guided injections than the landmark guided injections. The use of image guidance is strongly considered in patients with suspected extra-articular involvement to delineate the needle position. Intra-articular SIJ without imaging should not be performed. Fluoroscopic guidance should be coupled with contrast injections until and unless contraindicated. Ultrasound guidance should be considered in patients where radiation exposure or contrast is contraindicated. However, its accuracy depends more on the proceduralist and the patient characteristics. There is insufficient evidence to compare the accuracy of the CT-guided or ultrasound-guided injections to the fluoroscopically guided injections. Which is more effective for SIJ complex pain, intra-articular or the extra-articular injections? There is strong evidence for the efficacy of extra-articular with corticosteroids at least for 1 month. However, there is conflicting evidence on superiority of extra-articular injections at 3 months. The optimal technique for performing intra-articular injections include fluoroscopic guidance, access to the inferior portion of the SIJ, use of contrast medium to confirm the appropriate spread, and a low injectate volume less than 2.5 ml. And if the inferior access is not possible, then middle or superior access can be considered or CT guidance can be considered. The optimal technique for performing SLB-RFA includes fluoroscopic guidance, multi-site and multi-depth sacral lateral branch blocks, targeting the lateral branches of the S1 to S3 it must include the branches from S1 to S3. The ultrasound guided multi-site block should be given along the sacral lateral crest to target the posterior extra-articular structures and can be considered for prognostic sacral lateral branch blocks. Routine use of sedation is not recommended for diagnostic SIJ injections or therapeutic SIJ injections. However, light or moderate sedation can be selected for therapeutic injections can be used in for therapeutic injection in selected cases such as severe needle phobias, psychiatric indications, history of severe vasovagal reactions, or movement disorders that preclude the safety of the injections in these patients. Light or occasionally moderate sedation can be used for SLB RFA, and if sedation is used, the lowest dose of short-acting medications should be administered. There is indirect evidence that physical therapy and structured exercises may provide intermediate-term benefits. Cognitive behavioral therapy may benefit in patients with psychological issues. Physical therapy combined with cognitive behavioral therapy does not reduce transition from acute to chronic low backache. NSAIDs and SNRIs may help. There is no benefit from long-term opioid therapy or acetaminophen for SIJ complex pain. There is some evidence that SIJ belts may provide benefit, and there is insufficient evidence for acute use of opioids or the chiropractic treatment. So to summarize the guidelines so far, ma'am, here I have highlighted the grade B or the grade A recommendations. The prevalence of SIJ mediated pain in chronic low back pain is estimated to be 15 to 30%. However, further studies are needed to evaluate the prevalence of dorsal ligament mediated pain using extra-articular injection or sacral-lateral branch blocks. There is low quality of evidence that history and physical examination features may help predict intra-articular SIJ injection response. The specificity of provocative test is much lower than the sensitivity, with negative tests being more predictive than the positive ones. History and physical examination can help guide diagnostic injections, but it can be given even without positive provocation tests. The intra-articular SIJ injections are diagnostically valid for SIJ pain. Sacral lateral branch block are diagnostic for pain arising from the extra-articular sources. However, it is recommended that systemic reviews partially support the diagnostic validity and more studies are needed. Further, pragmatic trials directly comparing the diagnostic criteria are warranted. Intra-articular SIJ injection should use a maximum of 2.5 ml injected to avoid capsular rupture, and injection can be halted even at a lower volume if the resistance is met even at a less volume than 2.5. Response to diagnostic intra-articular injections can be used to select candidates for fusion surgery. Fluoroscopically guided intra-articular SIJ injections are more accurate than the landmark guided injections, and landmark guided injections should not be performed at all. Image guidance should be strongly considered when extra-articular involvement is suspected. Ultrasound guidance may be used in patients with contraindications to radiation exposure or in patients with contraindications to use of contrast. Preferred intra-articular SIJ technique includes fluoroscopic guidance, inferior joint access, use of contrast, and low injectate volume. For SLB RFAs, the fluoroscopic guidance with multi-site, multi-depth sacral lateral branch blocks targeting S1 to S3 is recommended. Routine sedation is not recommended for diagnostic or prognostic SIJ injection or the sacral lateral branch block injections due to increased false positive rates. And if the sedation is required, the lowest dose of short-acting agent should be used. Physical therapy combined with cognitive behavioral therapy does not reduce the risk of transition to chronic low backache. Thank you for your attention. I would like to invite Dr. Manoj for continuing with the guidelines.
Thank you, Dr. Anju. You've done a great job by assimilating all the important points from a article which was as long as 120 pages, and that was great importance to highlighting all the parts written in summary. So now may I invite Dr. Manoj to start from the next question.
Okay, sir. Uh, Thank you, ISSP Gurugram Branch, for giving me this opportunity for talking on this topic. So I will start with the question number 11. That out of if we are not using steroid, other things we can use for giving the intra-articular injections, and overall evidence is limited for this, and most are studies are small and uncontrolled. And usually these are very few randomized control trials. Like dextrose prolotherapy was used in one randomized control trial, and it suggested more than equal to 3 to 15 months benefit in very few patients, and it has grade C evidence. And for platelet-rich plasma therapy, there was two randomized control trial, one done in 2022, which favors steroid, and one done in 2017 favored PRP therapy. And it has also the grade C evidence for platelet-rich plasma. And for hyaluronic acid, there was one randomized control trial which showed that the corticosteroids with local anesthetic having superior results for 1 to 4 weeks compared to hyaluronic acid. And there was one small trial which used botulinum toxin, and that showed better pain and function with botulinum toxin compared to steroid injection for extraarticular injection at 2 to 3 months post injection pain relief. And for phenol or glycerol chemical neurolysis, there is very limited case series, and this should be avoided because it has longer. The potential side effects are there. So and safety concerns are there. That's why it has grade T evidence, and very limited study has used allogenic products like Wharton's jelly, platelet-rich fibrin, but there were these were uncontrolled data present, and this has also great D evidence, and this should not be used. And so guideline position is that there is insufficient evidence to recommend these routine use of these injectates compared to intra-articular steroid injection or extra-articular steroid injection. Then can we use cryoablation for sacroiliac branches? So advantage of using cryoablation is that it provides larger lesions, and it preserves the connective tissues, and it causes less neuritis and less nerve damage because it causes only grade 2 or grade 3 nerve injury compared to conventional RFA. And was found out that there was improved pain compared to steroid injection at 1 to 6 months in retrospective cohort study. And there was one case series and one small retrospective comparator study was done, which was compares the steroid with cryoablation, and there was no randomized control trial used using the anatomically validated technique. So the SIJ complex pain using the cryoablation has grade C evidence, so it should not be used. And this diagram shows the technique to use RFA, radiofrequency ablation. For usually we found out that the S1, S2, S3 branch, posterior sacral network is more important for doing the RFA. And technique, if we are doing left-sided RFA, for S1, S2, S3, we should use 3 o'clock position, 11 o'clock position, 9 o'clock position, or 7 o'clock position, and L5 dorsal rammers RFA. These are the and there is one other technique is leapfrog technique where we can use palisade technique. one is suggesting that from L5 to S3 we can do, or only L5 and then S1, S2, S3 in a bipolar leapfrog technique. Then there is their question number 13 was that sacral lateral branch radiofrequency ablation, how much effective is this? Then multiple randomized control trial was done, and it was found out that the sacral lateral branch radiofrequency ablation pain relief was comparatively more up to 3 to 6 months compared to same control group. And it was also found out that the standard medical management treatments like sacroiliac steroid injection or non-steroidal anti-inflammatory drugs, sacral branches radiofrequency ablation is more superior to that also. And pain relief was more than equal to 6 months in most of the patient, and in some patients got more than 12 months pain relief also, and it has grade B evidence. Then what targets and technique we should use? Usually for S1, S2, S3 lateral branches has grade A evidence, and for including the L5 dorsal ramus has grade B evidence. And we should include S4 lateral branch also if if the S4 foramen is at or above the inferior sacral iliac joint margin. And we should consider L4 also if there is lumbarization, or there is, if L4 is in a transitional anatomy where a sacroiliac joint is extended beyond up to the L4 vertebra. And preferred lesion technique uses are mainly the pooled RFA should be used with periforaminal targets, because it causes large lesions compared to conventional radiofrequency ablation. And we should consider also bipolar strip lesion compared to conventional single monopolar lesions. And L5 should be considered with S1, S2, S3 lateral branches. And for sensory and motor testing, sensory technique has limitation additional value with aggressive listening, and motor techniques should be used to detect unregired capture of sacral motor roots uh, uh, to delineate the bowel bladder involvement or leg weakness. Then the pain relief cutoff value, usually more than 50 equal to 50% pain relief should be considered for cutoff for diagnostic and prognostic sacroiliac injection to be positive for sacral lateral branch radiofrequency ablation. This has grade B evidence. And for prognostic procedure for before lateral branch RFA, if we consider extra-articular pathology, then then pain relief should be more than 50% for sacral lateral branch blocks. Then complication associated with sacral lateral branch radiofrequency ablation are usually self-limited. Mainly, might be post-procedural pain, increase in pain, local neuritis or neuropathic pain, hematoma, bruising. There can be transient paresthesia, and serious complications are very rare. Like injury to sacral roots can happen, rectal injury can occur, and skin burns can happen because of hardware we use. Then how to prevent these complications are, we should, guidelines is that we should use strict aseptic precautions, and fluoroscopy should be used for getting the proper view of in AP or lateral view before giving injection. And we should keep RF probes dorsal to sacrum away from foramina. And we should avoid direct contact with metal hardware or implanted electronic devices if patient has intracardiac defibrillator, or patient is having spinal cord stimulator. And we should also coordinate with the cardiology team or device team before doing RFA. And in these patients, we should consider for bipolar radiofrequency ablation compared to unipolar RFA. And if there is no relief with sacroiliac branch radiofrequency ablation, or and patient is not getting relief, then other options are also available, like fusion options. There are two approaches: open or minimally invasive. Or in open, there is anti-replating and lateral transarticular bone graft technique. And in minimal invasive technique, lateral approach is available, and anterior and posterior approach is available. For considering the fusion option, there is grade C evidence, and open fusion should be avoided because it has higher morbidity and compared to minimally invasive techniques. And these techniques can improve pain and function if there is no relief with conservative or minimally invasive techniques. And it was found out that the maximum pain relief with the even fusion options is not more than 12 months. So for considering the fusion options for patients, these are the criteria for first is pain characteristic. Pain should be non-radicular, predominantly below L5 in low back or buttock pain, and patient should be symptomatic for more than equal to 6 months. And there should be failed conservative options like physiotherapy, exercise, medication, even with less invasive techniques like injections or RFA. And physical examination, in physical examination, there should be more than equal to 3 of the 6 sacroiliac joints provocation tests should be positive. And we should rule out other possibility like might be hip pathology, there might be lumbar radiculopathy, inflammatory or destructive lesions. And before going for fusion techniques, there should be 2 injections should be given to the patient intraarticular, and there should be only local anesthetic should be given, no steroid should be given, and patient should report more than equal to 50% pain relief with functional improvement. But some societies suggested for more than equal to 75% relief in dual blocks, and some suggested more than equal to 50% pain relief. Then complication related to fusion options. There are common complication more with open and lateral minimally invasive approach. This is grade AA evidence. There might be persistent pain. Patient might be non-responsive to the treatment. There might be might need for revision or also in some patients, and there might be radiculitis after the injection after the fusion surgery. And hematoma infection can happen. A device-related problems like malposition, loosening, and migration can also happen in these patients. To reduce the risk in these patients, we should carefully perioperatively imaging and planning should be done. Intraoperatively, neuromonitoring, intraoperative navigation or imaging can be done, should be done to rule out any avoid L5, S1 nerve root or blood vessels. And smoking cessation and risk factor optimization should be done preoperatively in these patients. And post-operative monitoring should be done for any neurological changes. Then this flow chart shows that if the patient has sacroiliac joint pain, how we should proceed. So if we consider any patient for intra-articular pathology, we suspect, then we should give low volume intra-articular injection with steroid, local anesthetic. Then if patient gets more than pain relief for more than equal to 3 months, then we can give repeat injection if there is no relief after 3 months, and it can be repeated also. And if patient doesn't get pain relief for less than 3 months, then we can consider for intra-articular PRP injections. And still patient does not get any relief, then low volume intra-articular injection without steroid should be given before considering for minimally invasive fusion surgery. And even if the patient does not get pain relief with intra-articular steroid injection, then we can consider for extra-articular pathology, and we can give extra-articular injection. And if there is no response, then we should consider for any non-sacroiliac pathology. And if we consider for extra-articular pathology, then we can give extra-articular injection or combination of extra-articular or intra-articular injection with steroid. If patient gets more than pain equal to 3 months pain relief, then repeat injection can be given. And if pain relief is less than 3 months, then we can consider for porotherapy or prognostic sacroiliac branch blocks before considering for RF ablation. If patient does not get any pain relief with the extra-articular injection, then intra-articular pathology or injection can be considered. Or if there is no response, then non-sacroiliac pathology can patient might have non-SIJ pathology. Then this SIJ complex pain is common, and it is 15 to 30% in low back pain patients, and frequently it is misdiagnosed. Diagnosis can be done on history or with provocation test and image guided diagnostic test. And conservative care is reasonably first line, but limited SIG specific evidence is there. Intra-articular and extra-articular injections with corticosteroid can provide short-term relief, and evidence marginally favors extra-articular pathology for more than equal to 4 weeks. Sacral lateral branch radiofrequency ablation using anatomical valid techniques and appropriate selection offers good benefits for more than equal to 6 months. And SIJ fusion surgery should be reserved for carefully selected and refractive patients. These guidelines emphasize multimodal stepwise management and personalized approach. Thank you. This is.
Sorry, thank you, Dr. Manoj. So this is an infograph. I again got this from LinkedIn. I shared with Dr. Manoj. Again, this is all again showing again summarizing all the most of the major points of the article. Like it is mentioning epidemiology incidence, high sensitivity, also mentioning negative test rule out SIJ pain in 92%. Diagnostic accuracy of injection guidance is less by anatomical and more by fluoro and ultrasound. Intervention like we should limit volume to 2.5 ml. There's a strong evidence for lateral branch RFA, and also 1 year relief with minimally invasive fusion with very careful selected patients. So, Dr. Anchal ma'am, can we take questions now if there's anyone?
Yeah, there is one question from Dr. Karthik. How to differentiate intra-articular and extra-articular pathology based on history and clinical examination? Any of the faculty would like to answer that? Varsha ma'am. Dr. Varsha, can you hear us?
I can hear you. Actually, exactly that's the point I was looking at in the last slide where there was a flow chart. And if you see in the flow chart, exactly, yeah, this is the one. If you see the last limb of these flow charts, when we suspect intra-articular pathology and there is no pain relief with diagnostic injection, consider extra-articular and vice versa in this limb. When we suspect extra-articular and we inject, again, here I'm not clear. I would like to ask Dr. Manoj.
Yes, ma'am.
If it is a combination of extra-articular plus intra-articular, how would we able to differentiate if it is extra-articular or intra-articular pathology?
With injection only, ma'am.
Yeah, with injection.
Ma'am, if patient does not get relief even with means patient has both pathology.
Exactly. If you are putting both, see as per this flow chart, extra-articular plus intra-articular, yes, then how would you distinguish? Patient gets relief with both the injections you are putting, right? Like this article says. Then how would you distinguish if it is extra or intra? Is my question clear?
No,
Yes,
ma'am.
I think
You
yeah,
are putting.
I'll help Dr. Manoj here. I think the intra-articular injection they are asking to do it first if you are suspecting SIJ
Yes,
pathology, and if
yes.
there is no response, then
Then we
think
can
about
go.
extra-articular.
Yeah. So like it has got more of a negative diagnostic value.
Mhm.
Exclusion,
Yeah,
diagnosis after exclusion. And the question asked is on history and clinical examination, right?
yes.
How would you differentiate if the pathology is intra-articular or extra-articular? As it was in Dr. Anju's presentation, right? The examination part, when we started with SIJ joint anatomy and ligaments were covered along with joints. And then there are tests for SIJ. And
Yes,
she has
ma'am.
mentioned that Gansland test has the maximum diagnostic value.
Ma'am, but still, they say that the negative predictive value is much more than the
Exactly.
positive predictive value. So we still cannot say that positive Ganslin is diagnostic or positive. Even, ma'am, if we see the ASPN guidelines 2024, they said that 3 or more tests, provocative test positive, can be used to differentiate a intra-artic to say that it is SIJ complex mediated pain and we should go for injections. But these guidelines clear it very well that it is still the sensitivity of cluster of test or the individual test, it is much lower than the specificity is much lower than the sensitivity. So these tests could be even if these tests are not present, are not positive, even there are 2 tests positive, but we still consider based on the history and our clinical suspicion is strong that it is more of SIJ pain, then we should go for intra-articular injection, diagnostic injections.
Right. So the question asks specifically on
और
history
मैम
and examination. Dr. Anju, yeah.
एक पॉइंट और है इसमें स्टार्टिंग में लिखा हुआ prevalence rate of extra articular pathology is probably similar, perhaps even higher in younger individual with post traumatic pain. और एल्डरली में मोस्टली ये इंट्राआर्टिकुलर पेन ही होता है, और दूसरा अगर कोई इन्फ्लामेटरी आर्थराइटिस है, कोई इन्फेक्शन है, तो वो इंट्राआर्टिकुलर ज्यादा माना जाएगा।
नहीं दीप, इसमें मेरा क्वेश्चन ये है, जो सेम आई एम कंटिन्यूइंग विद द सेम क्वेश्चन दैट वाज आस्क्ड। जब अपन क्लिनिकल एग्जामिनेशन करते हैं एंड वी नो दैट इट इज ए पेन कमिंग फ्रॉम एसआईजे कॉम्प्लेक्स, इज देयर एनीथिंग by which we can know that it is extra articular or intra articular on clinical examination and history? Is there any specific point in these guidelines or somewhere some literature?
नहीं है सर, ऐसा कुछ ब्लैक एंड व्हाइट कुछ नहीं है
sir. Only by giving sacroiliac branch blocks we can identify that this is extra articular pathology. If we give only local anesthetic in the sacroiliac branch diagnostic block, then we can only know the extra articular.
एक तो सर ये ब्लैक एंड व्हाइट कुछ नहीं है, और एक ये कह रहे हैं कि एसआईजे पेन बोलना बंद करो, एसआईजे कॉम्प्लेक्स पेन
बोलो। ठीक है,
कॉम्प्लेक्स, करेक्ट, दैट इंक्लूड्स द एक्स्ट्रा एज वेल एज इंट्रा।
और सर वैसे जो मतलब मेरे को ये समझ में आई है कि नेक्स्ट टाइम से एसआईजे में इंट्रा आर्टिकुलर एक्स्ट्रा आर्टिकुलर दोनों काम कर दो ब्लॉक में, डायग्नोस्टिक में।
तो फिर कैसे पता लगेगा कौन सा कहां से आ रहा है?
सर बाद में आरएफए तो नर्व का ही करना है ना सर,
तो अपन यही करते हैं और सारे
जो प्रैक्टिकली करना है सर। मतलब मैं तो नेक्स्ट टाइम तो यही करूंगा सर।
नहीं डॉक्टर दीप, दैट्स नॉट द राइट मैसेज ऑन दिस प्लेटफॉर्म। ओके, so what you are saying practically that might be a more preferred way.
Yes,
right, but when we are discussing on this platform, the message should be
very. But ma'am, there is nothing harm in doing
Dr.
it.
Deep, there is no there. Of course,
yeah.
I mean, we are discussing this because we want to make some guidelines for young pain physicians, and
yeah,
I mean, for that matter we can do everything. Can is not the question here. It's like what we should do as a group, what should learning message.
That's fine, Dr. Aanchal, but if you go through all these guidelines, there is nothing very definitive for anything.
But as she
that
said
is for
in the
sure.
beginning,
This is
whatever
this
is
is
the history and examination, like in history, like he said, and if you remember our first journal club, which was on SIJ, the age of the patient, if the SIJ we know is mostly in the old age rather than young, except in ankylosing spondylitis, which is suggested by many other things, many other tests. So extra-articular is more in, that is just a suspicion, not of course black and white, but in young patients, SIJ is more likely extra-articular, and then as you age, the intra-articular is more. Of course, you can
okay.
confirm with
And
your diagnostic block.
if you notice, Dr. Ashu and Dr. Achal, in the limb of that flow chart, for intra-articular, there is specific PRP recommendation, okay, for intra-articular. So if we are putting PRP in the ligaments also and intra-articular also. But when it is specific intra-articular, there is an option of PRP. Every time we don't have to go for lateral
अंचल
sacral
मैम का तो
branch.
एक्सपीरियंस है SIPRP में.
हाँ.
No, SIG PRP actually helps, but I mean, as you age, the PRP is not as beneficial. So you have the limitation of PRP after certain age. So I mean, everyone who is doing PRP, I'm sure, they must have this, like even in knee PRP, who we swear by, in very old people, they don't respond that much as we do in 40s or 50s.
Right.
और एक और मेरा क्वेश्चन है यहाँ पे, वो कहते हैं ना द एक्स्ट्रा आर्टिकुलर शुड बी गिवन ए डिफरेंट डेप्थ, उसका एग्जैक्ट क्या मतलब है?
हाँ,
अगर
exactly.
मतलब मैं आज इफ आई एम ट्राइंग टू डू दैट, व्हाट डज दैट एक्चुअली मीन? व्हाट शुड आई डू?
सर थोड़ा सा बाहर विड्रॉ करना है बोन पे देने के बाद, इतना ही लिखा हुआ है.
अच्छा,
मिलीमीटर विड्रॉ.
As you come out of that, when you go into the joint, आपको एक feel आती है dip की, and you just have to come out a millimeter.
नहीं, आई एम टॉकिंग अबाउट एक्स्ट्रा आर्टिकुलर.
एक्स्ट्रा आर्टिकुलर ही बोल रही हूँ सर, जस्ट आप जब वो फील आती है, जब आप उससे बाहर आते हो, तो दैट इज एक्स्ट्रा आर्टिकुलर.
ओनली दैट.
दैट इज
हाँ
व्हाट
सर, जैसे बोन पे रख के दिया, थोड़ा सा मिलीमीटर विड्रॉ किया, मल्टी साइट मल्टी डेप्थ.
बस यही है ना बात, उसमें
जी
कोई
जी, इतना ही है.
स्पेसिफिक इशू तो नहीं है ना?
उसमें कुछ नहीं है ना.
इन्होंने बकायदा 3 mm लिखा, लेकिन वो पता नहीं कैसे मापा जाएगा.
Anshul ma'am,
हाँ बोलो.
ma'am, are you saying the pericapsular? That I mean, sometimes we no, peri as in sometimes we just prick the capsule and we deposit there. No, that is what you mean by extra-articular.
We have to come outside the capsule into the ligaments.
Okay. ठीक है.
Dr. Pradeep, you were saying something. Dr. Pradeep Attar.
Yes, ma'am. I just wanted to ask, जो posterior ligaments हैं, मतलब in young patient, the extra-articular, the earlier understanding was that posterior ligaments are more likely to get affected there. So, will fluoroscopy be of similar value, or will we like to go using ultrasound or something else?
Actually, in these guidelines, Dr. Anju, when she was presenting, she was showing that, fluoroscopy is the first choice, unless it's pregnancy or because it's easier.
Grade B evidence.
Yeah. So for SIJ, I think the guidelines are still saying use of fluoroscopy. But and ultrasound is user dependent as well.
इसमें मैम इन्होंने इंटीरियर जॉइंट पेन के बारे में ज्यादा कुछ नहीं डिस्कस किया ना?
नहीं डिस्कस
वही
किया. Anterior
मतलब ज्यादा स्टडीज नहीं है. वेंट्रल L4 L5 वेंट्रल रेमस को एड्रेस करना चाहिए, नहीं करना चाहिए?
L5 वेंट्रल रेमस नहीं, L5 डॉर्सल रेमस.
वो एक या दो स्टडी में लिखा हुआ है कि करना चाहो तो L4 L5 वेंट्रल रेमस को भी आप ब्लॉक कर सकते हो. लाइक उसका RFA तो PRF ही होगा, अदरवाइज आप ब्लॉक कर सकते हो. एक दो स्टडीज में एक दो लाइन लिखी हुई है छोटी छोटी.
वो कैसे? वो कैसे?
SNR भी कर दो सर.
DRG?
हाँ जी
हाँ जी सर.
अच्छा, चलो आप कह रहे तो मान लेते हैं.
थैंक यू सर. ये वेंट्रल इंटीरियर जॉइंट भी मतलब कितना पेन देता है कितना नहीं देता, वो कैसे वो नहीं पता चलता ना.
हाँ,
और एक जगह पे उन्होंने मोर लाइक 50% रिलीफ ऑन मोर देन 2 इंजेक्शन और एक जगह पे 75 लिखा है, तो उसके बारे में हमें कैसे क्लैरिटी है?
मैम वो पूरा ग्रुप कहता है मोर देन 50 होना चाहिए, 3 सोसाइटी कहती है मोर देन 75
75
होना
होना
चाहिए।
चाहिए।
वो कंसेंसस और रिकमेंडेशन ऐसा उन्होंने नाम अलग किया, राइट?
कंसेंसस
मोर
ग्रुप,
देन
जो
50
ग्रुप
है तो
कंसेंसस है
रिकमेंडेशन। हाँ,
वो 50% पे आ गया है
ओके, सो शैल
दोनों।
वी कंटिन्यू विथ 50 इन प्रैक्टिस?
50, वो तो
That is
that's
for
for any
SIJ
other.
fusion.
Not for SIJ.
Not
That's
fusion,
for
even
any other
RFA.
RFA.
हाँ,
Any
even
other,
RFA.
when we do, we always do more
Definitive
than 50%.
procedures.
For
सिर्फ
RFA
RFA
only, there is only 50%, ma'am. For RFA.
ब्लॉक के लिए भी सेम है।
Cut off value is 50%. They were saying for sacral fusion more than 70.
Okay, got it. Right, any other question, audience?
फ्यूजन का फाइनल रिकमेंडेशन क्या है? पोस्टीरियर फ्यूजन है कि लैटरल फ्यूजन है? मतलब MIS वाले में जो करते हैं।
Oh, anterior and posterior should be preferred because
पोस्टीरियर
it
शुड बी
because it causes less blood loss and less morbidity.
ओके, पोस्टीरियर फ्यूजन, पोस्टीरियर लैटरल मतलब
हाँ
पीछे
जी।
से। ठीक है, ओके, थैंक यू।
Hello.
और एक
Sir,
चीज
Manoj
और
sir,
मैम,
Doctor,
I have one doubt, sir.
yes, please.
Manoj sir, you have mentioned the sacral lateral nerve block. If it has the pain relief, means it suggests the extra-articular pathology.
Yes.
So, could we consider RFA only for extra-articular pathology?
No, we can consider for intra-articular also.
Intra-articular
Long
also.
term, because intra-articular will give you relief for short term, like 3 months, he was saying. But RFA you can consider for, if you're sure that your diagnostic is positive, you can consider RFA for long-term relief.
Okay, thank you.
So
एक चीज
basically,
और
as
मैम,
Dr.
हम लोग
Deep
तो
mentioned, it is very thin line to distinguish between extra and intra-articular,
Yes.
And most of the time, the procedure which you do, definitive procedure, when you are going to explain the patient, it really has to give them the relief. So it works
मैम
for
एक
both.
चीज और, इन्होंने L5 डॉर्सल रेमस और L4 मीडियल ब्रांच का, मतलब ठीक है वो RFA हम करते हैं, जैसे मैं सर के साथ था तो पहले हम करते थे और अब वही प्रैक्टिस अभी करते हैं। तीनों लेवल पे कूल करने के बाद ऊपर पे L5 डॉर्सल रेमस और L4 का मीडियल ब्रांच करते हैं। मतलब उसमें इन्होंने ये नहीं मेंशन करा, जस्ट एक सिली क्वेश्चन है कि भाई उसका थर्मल करें या कूल करें, मतलब वो जो जिसकी प्रैक्टिस है वो कंटिन्यू कर सकता है।
L5 when you are doing say lateral sacral cool कर रहे हो अगर आप, तो obviously L5 का भी you'll do cool. उसका
हाँ मैम,
conventional
सब
क्यों
कोई
करोगे?
थर्मल करता है फैसेट्स पे, कोई कूल करता है, वो वैसे है।
But if you are doing cooled or just extra lesion के लिए, why would you choose something?
नहीं, we do from day one L4 L5 thermal and then followed by cool
हाँ
RFA.
मैं
What is the
इसीलिए
problem
क्वेश्चन
in that?
इसीलिए कर रहा था, पूछ रहा था।
हम सब में
और
ऐसे ही करते हैं, पहले we do
आप separate
thermal.
kits open करते हो फिर?
Yes,
same procedure.
yes, definitely. So L4 L5 do thermal and then cooled for radio. We always do that only.
Sir, L4
मतलब मैंने
L5 cool क्यों नहीं कर सकते?
मैं
कर
मैडम
सकते हैं ना।
उस बारे में हम बड़ी डिटेल डिस्कशन कर सकते हैं एनाटॉमिकली किसी दिन बैठ के, कि हम फैसेट RFA में कूल करना क्यों डिजास्टर्स है। वो किस पे मैं किसी दिन स्ट्रक्चर सेपरेट चैप्टर ले सकता हूँ विद एनाटॉमी एंड एवरीथिंग।
ठीक है।
ये मेरे हिसाब से टू डू cooled RFA of medial branch in facet, lumbar facet is a disastrous thing. And why someday we will sit with anatomical knowledge and I'll explain why. So मैं नहीं करता बिल्कुल भी।
Okay.
तो उसके बारे में हम किसी दिन सेपरेटली क्लास रख सकते हैं उस बारे में। So we'll start with the anatomy and then
Next class कर दो
give
सर
my views and why it is dangerous.
Next
कूल्ड वाले नाराज हो जाएंगे। Thoracic facet, like thoracic facet, big yes. I am now doing all thoracic facet cooled RFA. Tomorrow I'll do again thoracic facet cooled RFA. We can do cervical facet cooled RFA, but there is a serious problem in lumbar facet cooled RFA. I'll tell you why.
एग्जिटिंग नर्व रूट सर काफी पास होती है उसके, क्या मीडियल
Exactly, वो टिप से बियॉन्ड लीजन एक्सटेंड करता है, आपका ग्रूव पे कोई कंट्रोल नहीं है। ये सब बातें मैं एनाटॉमिकली आपको बताऊंगा अच्छे से। सो मैं तो लोगों को मना करता हूं कि आप प्लीज लंबर फैसेट में कूल्ड RFA मत करो, समडे यू विल बर्न योर नर्व रूट। So that is not a good technique according to me. I may be wrong, but I don't practice.
तो ये आर्टिकल L5 डॉर्सल रेमस का RFA ज्यादा मतलब को एड्रेस करने बोल रहा है, और उसने कुछ RFA का ये नहीं बताया कूल या थर्मल,
हाँ
और दूसरा L4 का बीच बीच में इनकंसिस्टेंट कंट्रीब्यूशन
एग्जैक्टली
है।
तो जब जहाँ पे आपका सेक्रेलाइजेशन वगैरह होती है ना,
हाँ
वहां
जी, हाँ
पे
जी, हाँ
आप
जी,
कर सकते हो, पर अपन
हाँ जी,
रूटीन में करते हैं L4
L5
L5
तो
का
हाँ
वजह से।
सबमिटेड है ही है SIJ के साथ,
हाँ
टेक्निकल
जी,
हाँ जी, हाँ जी।
L5 तो करते ही हैं।
तो SIJ की आप जब डोर्सल रिमाई देखोगे ना, L4 इज प्लस माइनस ऑलवेज, तो यू कैन ऑलवेज डू, जब आप L5 कर रहे हैं तो L4 भी कर देते हैं, टेक्स अ मिनट।